Hello and welcome to today's presentation. Today we shall be looking at pediatric conditions, specifically the endocrine and the metabolic disorders. On our learning outcomes, we need to identify the major endocrine glands in our body, describe common endocrine disorders, explain the pathophysiology and clinical significance of these metabolic disorders in patients, also outline the importance of early detection, diagnosis, and treatment in improving the outcome for children. And lastly, attempt to come up with several nursing diagnoses affecting all the conditions that we have stated. Of course, we'll begin by defining what a pediatric patient is. According to WHO, World Health Organization, a pediatric, which is commonly referred to as a Ped, is a patient that refers to any individual from birth up to 18 years of age and requires medical care. So the WHO further clarifies pediatric groups into several subgroups. We have neonates. This is from birth to 28 days, infants 29 days to 12 months. Then you have young children 1 year to 5 years, older children 6 to 12 years, and then adolescent 13 to 18 years. WHO emphasizes that pediatric patients have unique physiological, development, and psychosocial needs requiring age-appropriate care and treatment. So back to the endocrine system, and we're saying that the endocrine system is composed of several glands throughout the body. These glands normally release chemical messengers that are referred to as hormones. These hormones control and regulate the activity of target cells and organs. Hormones also influence growth, development, digestion, regulate metabolism, and even reproduction. So glands will release hormones into blood to a stimulus, to another hormone, or to meet a threshold. We have several glands in the body, starting with the control center, which is the hypothalamus, followed by the master gland, the pituitary gland. Then you have the pineal gland, the thyroid gland, the thymus, the pancreas, adrenal glands, the renal glands, and lastly the gonads, which include the testes and the ovaries. So glands will stop releasing hormones when they receive a signal to turn off the hormone production, and this is through a process called direct feedback, which can either be positive or negative. The endocrine system maintains the homeostasis. Feedback tells a gland to either increase or decrease the hormone production so that the body returns to homeostasis. So when the concentration of a hormone reaches a threshold, hormone production will be turned off. One of the most common glands that is affected is the thyroid gland. Thyroid gland is located in the anterior neck that is overlying the trachea. The thyroid gland makes several hormones. We have what we refer to as the metabolic hormones, the T4, T3. T4 is the thyroxine hormone, which regulates carbohydrate metabolism, lipids, proteins, growth, and development. T3 is the triiodothyronine. It regulates carbohydrate metabolism, lipids, proteins, growth, and development. We also have the C cells in the thyroid, which normally produces calcitonin. Calcitonin is involved in regulation of blood calcium and phosphate release from the bones. So remember, we have the control center, which is the hypothalamus, which normally secretes the TRH. The TRH stimulates the pituitary gland to release the TSH. The TSH now is the one that is now stimulating the thyroid gland to release the T3 and the T4. The pituitary gland, of course, is a pea-sized gland and connected with the hypothalamus, and it's divided into two parts. We have the anterior pituitary gland, which is referred to as adenohypophysis, and the posterior, which is the neurohypophysis. So, looking at some of the hormones produced by the anterior pituitary gland, we have the TSH, which stimulates the thyroid gland to produce hormones, the T4 and the T3. The growth hormone, which increases protein synthesis, increases fat mobilization, decreases the use of carbohydrates, all of which encourages tissue growth. Follicle-stimulating hormone, the FSH, stimulates the Graafian follicles to mature and secrete estrogen in females and stimulate the seminiferous tubes development in males. Luteinizing hormone, LH, causes the rupture of the follicle, resulting into the release of an ovum in female. In males, it stimulates production of testosterone. Prolactin hormones stimulates the secretion of breast milk. Well, the adrenal hypophysis produces a number of hormones. Of course, on our left, we can just remind ourselves that we have the growth hormone, the prolactin hormone, the thyrotropin. We also have the adenocorticotropin. We also have the follicular stimulating hormone, luteinizing hormone, and the beta lipotropin. Let's also look at the posterior pituitary gland. It's also referred to as the neurohypophysis. The neurohypophysis. Remember, the pituitary gland sits in the cella tussica of the sphenoid bone, right? Okay, so we have oxytocin. Oxytocin stimulates the uterus contraction and also the letdown of the lactation reflex. ADH, the vasopressin, antidiuretic hormone, regulates the concentration of fluids in the body by altering the permeability of collecting ducts and the distal convoluted tubes in the kidneys. The second gland is the adrenal gland, and the adrenal gland are located at the top of each kidney in the retroperitoneum. Adrenal glands are composed of two parts. We have the outer layer, which is the adrenal cortex, and the inner layer, which is the adrenal medulla. When you look at the adrenal cortex, it's further subdivided into several layers. We have the outermost layer, which is the zona glomerulosa, followed by zona fasciculata, lastly we have the zona reticularis. Zona glomerulosa produces aldosterone. Aldosterone is responsible for renal reabsorption of sodium and excretion of potassium. It also helps balance the electrolytes and water. The second layer is the zona fasciculata. Zona fasciculata produces cortisol, which is a glucocorticoid that stimulates gluconeogenesis, lipolysis, and proteolysis. It also manages the body's stress response. Lastly, we have the zona reticularis. The zona reticularis is the innermost layer. It is associated with the production of androgens, which are male sex hormones that promote secondary sex characteristics. If you look at this in terms of percentage, you find that the most burdened part of the cortex is the zona fasciculata, which is the middle layer. It's made up of about 78%, followed by the outermost layer, which is the zona glomerulosa, 15%, and then now we have the zona reticularis, about 7%. Remember, if you compare the cortex and the medulla, the cortex makes up 80% of the weight of the adrenal gland, while the medulla only 20% of the weight. And the adrenal medulla is mainly responsible for production of catecholamines. Catecholamines include epinephrine. We have epinephrine, which normally increases the heart rate, respiratory rate, blood pressure, and also dilates airway and also increases the metabolic rate. Second, we have the norepinephrine, which increases the heart rate, respiratory rate, and blood pressure, and dilates airway and increases the metabolic rate. The other hormone here, we have the dopamine. Next, we have the parathyroid glands, and the parathyroid gland are composed of usually 4 or more small glands located on the posterior side of the thyroid gland. The parathyroid gland produces PTH, the parath hormone, or the parathyroid hormone. Parathyroid hormone normally maintains calcium level in blood and inhibits phosphorus. So if the serum calcium level falls, PTH is now released by the bones, right? Released by the bones to break down, releasing calcium in blood. Equally, kidneys will be able to retain calcium in blood, and also there will be the intestines. The intestines will also have activated vitamin D, helping absorbing calcium in the GIT. So the parath will have effects on the bones, effect on the kidneys, effect of intestines, all geared towards increasing the serum calcium level. The other gland is the pancreas. Pancreas is made up of the what we refer to as the cluster of cells, the islets of Langerhans. The islets of Langerhans produces several cells. We have the alpha cells producing glucagon, beta cells producing insulin, delta cells producing somatostatin, and the PP cells producing the pancreatic polypeptide. Remember, insulin is responsible for increasing cellular use of glucose, while glucagon, which is produced by alpha cells, increases glucose when the blood level of glucose is low. Somatostatin is produced by the delta cell, and somatostatin normally inhibits the release of corticotropin and the growth hormone. We also have the gonads, and the gonads are sex glands and will include testes in males and ovaries in females. So ovaries are going to be producing estrogen, which promotes secondary female characteristics and regulates the menstrual cycle. We also have progesterone hormone, which supports pregnancy and prepares breast for lactation. Males, we have the testes, which are going to be producing this testosterone, which stimulates production of spermatozoa and also maintains secondary male characteristics. So after looking at some of the glands, we can now move ahead and look at some of the top 10 conditions in each category. Like for the endocrine disorders, we have the type 1 diabetes, we have the congenital hypothyroidism, hyperthyroidism, especially the Graves' disease, growth hormone deficiency, precocious puberty, adrenal insufficiency, what is commonly referred to as congenital adrenal hyperplasia, abbreviated as CAH. Then on the metabolic disorders, we have the phenylketonuria, abbreviated as PKU. We also have galactosemia. We have the maple syrup urine disease, mitochondrial diseases like the Leigh syndrome, and the glycogen storage disease like the type 1 and type 2. We can have the congenital hyperthyroidism first, and this is because this is a lack of or too little thyroid hormone during fetal development or following birth, resulting from underdeveloped or absent thyroid glands. It is normally caused by the mother's iodine deficiency or taking antithyroid medication during pregnancy or from autoimmune thyroiditis. Congenital hypothyroidism affects the growth of the nervous system and the bones and affects the mental development if left untreated. The most common test point in NCLEX, we have this is what you need to know, that treatment of congenital hypothyroidism must begin within 3 months of age to ensure normal development of the Peads. In terms of assessment of a patient with congenital hypothyroidism, patients are going to present with fatigue due to slow metabolism, noisy respiration due to enlarged tongue, and you can be able to see it on our right here in our diagram. We also have hypothermia due to slow metabolism, short, thick extremities and neck, brittle nails due to low levels of thyroid hormone that helps growth and development, thin, dry hair from lack of thyroid hormone, dry skin from lack of thyroid hormone, slow cognitive function due to slow metabolism, weight gain due to low levels of thyroid hormone that causes fatigue and sluggishness, and lastly, cognitive impairment due to untreated condition. So you have to treat it within 3 months. In terms of diagnostics, we have the thyroid scan, which shows decreased uptake of iodine or absence of thyroid. Serum TSH, thyroid stimulating hormone, will show that there is increased TSH unless the cause is due to a decreased production of TSH by the pituitary gland. Serum thyroid hormone will show decreased T3 and T4, triiodothyronine and thyroxine hormone. Radiograph will show absence of tibial or femoral epiphyseal line, And electrocardiogram will show flat or inverted T waves and bradycardia. Remember, in congenital hypothyroidism, we have the 6 P's, where we have the potty-bellied, the patient will be pale, will have puffy-faced child, protruding umbilicus, that is umbilical hernia, protuberant tongue, and poor brain development. In terms of treatment, we could do replacement. We could replace the hormones, and this one we normally administer levothyroxine or the leutyronine. Serum measurements of T3 and T4 will need to be performed after 6 to 8 weeks to determine if the patient is taking the correct dose. The patient needs to be aware this is a lifetime replacement. Vitamin D supplementation to prevent rickets might result from rapid bone growth. Nursing intervention, you have to ensure that the newborn is screened for congenital hypothyroidism so that treatment can begin within 3 months of birth. You need to monitor vital signs because treatment may cause tachycardia and hypertension. You monitor for irritability, sweating, and fever that indicate that the dose is too high. You monitor for lethargy, constipation, decreased appetite, fatigue that indicates that the dose is too low. And you provide a warm environment, provide low calorie diet, and increase fluids and fiber to prevent constipation. Take thyroid replacement hormone each morning to avoid insomnia. Monitor for signs of thyrotoxis, that is an increase in T3, that nausea, vomiting, diarrhea, sweating, tachycardia. Explain to the family the side effects of the thyroid hormone replacement and review the signs of hyperthyroidism and hypothyroidism. Also teach the family that the treatment is lifelong. The other common prevalent endocrine disorder is the Cushing syndrome. Cushing syndrome occurs when the adrenal cortex secretes an excess of glucocorticoids or there is an excess secretion of adrenocorticotropic hormone, the ACTH, by the pituitary gland as a result of either a pituitary tumor or adrenal tumor or from ongoing glucocorticoid therapy. In terms of assessment, patients will have a moon face during excessive corticosteroid production. We'll also have present with weight gain. We'll have a buffalo hump. At buffalo hump, this is a fat pad located in the upper neck from excessive corticosteroids. Then you are going to have osteoporosis from an excess of corticosteroids, which weakens the bones. Patient will experience bruising, delayed wound healing, sleep disturbance, reddish purple stripe on the abdomen, and changes in mental status from excessive steroids. In diagnostics, we do dexamethasone suppression test where a dose of glucocorticoid is given to patient to test the hypothalamus pituitary adrenal axis. If there is suppression of a cortisol with the dose, it indicates that the pituitary is the origin of the problem of the excess cortisol. If there is no suppression occurs, the etiology is an adrenal or ectopic tumor. We also do a 24-hour urine collection where we look for increase in cortisol from excessive production. Also do CT scan, computed tomography scan where it can show presence of a pituitary tumor or adrenal tumor. We also have a serum where we'll also be noticing increase in blood glucose due to overproduction of steroids. Serum can also show increased sodium due to excessive fluid loss. Serum can also show decrease in potassium. In terms of treatment of the Cushing syndrome, we do surgical removal of the pituitary gland if it is the primary reason or the adrenal gland. Remember, the most common test point in NCLEX is that the child is highly susceptible to infection. Therefore, it is critical to prevent the child from being exposed to infection by putting them on neutropenic precautions. All right? Okay. Nursing interventions, you need to weigh the child daily to monitor fluid status. You monitor the child's input and output to ensure adequate hydration, monitor for glucose and acetone in urine because elevated levels of corticosteroids may produce hyperglycemia. Allow the child have adequate rest to allow the body to stabilize. Avoid skin because elevated levels of corticosteroid can also delay wound healing. Bone densimetry could be used to assess osteoporosis because corticosteroids can leak calcium from the bone. So following surgery where you have removed either the pituitary tumor or the adrenal gland, you need to assist in early ambulation, deep breathing, coughing, just to facilitate mucus mobilization and decrease risk for an emboli. You monitor for incision site for drainage, erythema, signs of infection. Also, elevate the head of the bed 30 degrees to reduce intracranial pressure. Explain to the family to maintain high calcium, high protein, high potassium, low carbohydrate, low sodium, low calorie diet to aid in wound healing and replace calcium. Administer pain medication as needed. Alright guys, the third condition, the third adrenal most prevalent endocrine disorder among the Peads is the adrenal insufficiency. This is the congenital adrenal hyperplasia, right? So it's congenital, that means it's from birth, right? And it's a group of autosomal recessive disorders characterized by enzyme deficiency in cortisol synthesis, leading to adrenal insufficiency and androgen excess. The most common cause is the 21 hydroxylase deficiency, nearly 90% of the cases. So we have types of the classic ACHCH, congenital adrenal hyperplasia, where we have the salt wasting form, which is the most severe, followed by the simple virilizing CH. So in the salt wasting, we have the cortisol and aldosterone deficiency leading to dehydration, hypotension, hyponatremia, and hyperkalemia. In simple virilizing CH, androgens excess without significant aldosterone deficiency, leading to ambiguous genitalia in females and early virilizing in males. For the non-classic congenital adrenal hyperplasia, could have late or mild onset. So we have partial enzyme deficiency with normal cortisol but excessive androgens, and it presents later in childhood or adolescence with signs of early puberty, hysterism, or menstrual irregularities. For the classic features, we have the neonates, which will where we have the salt wasting type. Patient presents with vomiting, dehydration, failure to thrive, hypertension, electrolyte imbalance. For the females with the classic congenital adrenal hyperplasia, we have ambiguous genitalia. For the males with the classic congenital adrenal hyperplasia, we have normal genitalia at birth, but may have early virilization, that is deep voice, muscle growth, and pubic hair. The non-classic congenital adrenal hyperplasia in both genders, they could present with early puberty, rapid growth, advanced bone age, and then you have arcing irregular menses in females. Remember, symptoms of congenital adrenal hyperplasia: not enough cortisol, excessive androgens, adrenal crisis, fertility issues, altered growth, and atypical genitalia. In terms of diagnosis, we do newborn screening where elevated 17-hydroxy progesterone could be there. We could also do serum electrolytes, and patient could present with hyponatremia, hyperkalemia, especially in the salt wasting type. We'll also do ACTH stimulation test, which confirms cortisol deficiency, and also genetic testing, which identifies the gene mutations. In management, we do the hormonal replacement. So we could do hydrocortisone, that is the cortisol replacement. We could do the fludrocortisone, that is aldosterone replacement for wasting congenital adrenal hyperplasia. Sodium supplementation in neonates. Could do also surgical correction, that is congenital restrictive surgery in females with ambiguous genitalia. We could also do long-term monitoring, that is growth, puberty, bone age assessment, stress dose steroids during illness and surgery to prevent adrenal crisis. The next and common endocrine disorder is DM. So certain foods are converted to glucose, which is the primary energy supply. Insulin from beta cells of the pancreas transport glucose into cell for cell metabolism. Diabetes mellitus normally occurs when beta cells either are unable to produce insulin, that is type 1 diabetes, or produce insufficient amount of insulin, type 2 diabetes. As a result, glucose doesn't enter cells and remain in blood. So increased glucose level in the blood will signal the body to increase the intake of fluid to flush glucose out of the blood in urine, resulting in increased thirst, increased urination in a patient. So cells become starved for energy because of lack of glucose and signal the body to eat, causing the patient to experience an increase in hunger. So there are three major types of DM. We have type 1, which is known as insulin-dependent diabetes mellitus, IDDM. Here, beta cells are destroyed by an autoimmune process. There is also a genetic predisposition, although the COX-B, MAMS, and congenital rubella virus injure those beta cells and can also result in type 1 diabetes. Type 2, it's also known as the non-insulin dependent diabetes mellitus, the NI. So here beta cells produce insufficient insulin. We also have another type, gestational diabetes, and this one is due to insufficient insulin produced by the mother during pregnancy. You have to know that patients with gestational diabetes normally recover following pregnancy. However, they are at risk for developing type 2 diabetes later in life. So we have type 1, type 2, and gestational, which seems to be under type 2, but that's also counted here as the third type of diabetes. The common test point, you have to know that patients with type 1 and type 2 diabetes are at risk for vision loss, that is diabetic retinopathy, damaged blood vessels, the nerves in the case of diabetic neuropathy, and the kidney damage, that is the nephropathy. However, complications can be minimized by maintaining a normal blood glucose level through consistent monitoring, administering insulin, and dieting. For the type 1, in terms of assessment, this one is normally fast onset because no insulin is being produced. So there is increased appetite that we refer to as polyphagia because cells are starved for energy and are signaling a need for more food. There is also increased thirst, polydipsia, from the body attempting to get rid of itself of glucose that is in blood. There is increased urination, polyuria, from the body attempting also to get rid itself of glucose. Patients also present with weight loss because glucose is unable to enter the cells. There is frequent infections as glucose feeds on the excessive glucose in blood. There is delayed healing because of elevated glucose levels in blood, which will hinder the healing process. As for the type 2, it is in slow onset because there is some insulin being produced by the beta cells. However, we could see patients with polydipsia, increased thirst from the body attempting to also get rid of itself of glucose. We also have polyuria from the body attempting to get itself rid of the glucose. We also have the candida infections. Candida infections as bacteria feeds on the excessive glucose, and we have delayed healing because elevated glucose levels in blood hinder the healing process. In terms of diagnostics of diabetes in this category, we could do urine test, which will show increase in glucose in urine, commonly referred to as glycosuria. We could also look at the fasting plasma blood glucose test. So a plasma glucose level of more than 126 milligrams per deciliter or 7 milliosmoles per liter on 3 different occasions could be suggestive of DM. We could also do the oral glucose tolerance test or GTT, where we find a plasma glucose of more than 200 milligrams per deciliter or 11.1 millimoles per deciliter after 2 hours of ingesting 75 grams of oral glucose could be suggestive of diabetes. Also, random plasma glucose test could show a plasma of over 200 or equal to 200 milligrams per deciliter or 11 is almost also suggestive of DM. And lastly, glycosylated hemoglobin AIC of more than or equal to 6% is also suggestive of DM. In terms of treatment, starting with D type 1, we have regular monitoring of the blood glucose. We administer insulin to maintain the normal blood glucose level and maintain a diabetic diet. So we could give different types of insulin. We have rapid acting insulin, which starts few minutes and lasts for about 2 to 4 hours. We have examples like the LAGs, Lispro, Aspart, and Glucosilin. We also have regular or short-acting insulin, which starts within 30 minutes and will be there for around 6 hours. And every time, in order to identify this type of insulin, you'll find on the vial it's written R, so it is regular. We also have intermediate acting, mostly the NPH, neutral protamine hegemon, and this one is it will be there, it will start working between 2 to 4 hours and has a duration of 12 hours. That means you need a dose, 2 dosage in a day. Long-acting insulin like glargine and Lantus, they'll take about 2 to 4 hours to act, and then they'll act full duration of 24 hours. So you just need single dose in a day. We also have inhaled insulin, which works within 10 minutes and for a period of about 3 hours, Exubera. For the type 2 diabetes, you maintain ideal body weight through diet and exercise. You do regular monitoring of blood glucose. You need to administer oral sulfonylureas. And the sulfonylureas include drugs like gliperamide, glipizide, and glyperide. This one, they stimulate secretion of insulin from the pancreas. The sulfonylureas also have the same mechanism of action with meglinitrides, and meglinitrides include drugs like leparinide, although their stimulation of insulin secretion from the pancreas is a bit slow compared to the sulfonylureas. The other agents, we have biguanides like metformin, which reduces hepatic glucose production. We have the thiazolidines like the rosiglitazines, the pioglitazines. They are also referred to as the glitazones. This one increases insulin sensitivity in peripheral tissues like the muscles. We have the D-phenylalanine derivatives like the nateglinide. This one promotes insulin production. Then we have the alpha glucosidase inhibitors, examples like acarbose and miglitol. This one, they delay carbohydrate absorption in the intestines. We have the DPP4 inhibitors like the sitagliptin. They are also referred to as the gliptins. This one, they prolong incretin hormone activity, enhancing insulin secretion. We have the incretin mimetics. This one stimulates insulin production, regulate hepatic glucose output, and suppress appetite, slowing gastric emptying. Then lastly, we have the amylin analogs like the pramlintide. This one is it's a slow glucose entry, promotes slow glucose entry in bloodstream and may aid in weight loss. These are injectable. Nursing interventions include educating the family and the child about the disease and the importance of maintaining the normal glucose level, demonstrating blood glucose monitoring, review diet and food choices including portion sizes, encouraging exercise, discussing skills to reduce stress, teaching self-injection of insulin, especially in type A, and teaching importance of daily medications, self-care, including insulin injection, and explaining to the family and patients the signs and symptoms and interventions for hypoglycemia, diabetic ketoacidosis, and hyperglycemia. The other condition is precocious puberty. Precocious puberty is the onset of secondary sexual characteristics before the age of 8 years in girls or 9 years in boys. And this is due to early activation of the hypothalamic pituitary gonadal axis, so referred to as the HPG axis. So we have two types of precocious puberty. We have the central gonadotrophin dependent, and we have the peripheral gonadotrophin dependent. So in the central, we have early activation of this axis, and it can be caused by idiopathic, which is the most common cause. For the peripheral gonadotrophin independent precocious puberty, we have excessive sex hormones from gonads, adrenal glands, and external sources, and the causes could include congenital adrenal hyperplasia, which you just looked at it. In terms of clinical features, like for the girls, we have breast development, we are going to have telaki, pubic hair, and pubic, that is early menarche. For the boys, we are going to have testicular enlargement, increased muscle mass, and voice deepening. We have accelerated linear growth and bone maturation, and possible mood changes or behavioral issues. Diagnosis, we could do the hormonal tests that will reveal elevated LH, FSH in central type. We'll also have low LH and FSH with elevated sex hormones in the peripheral type. We could also do the gonadotrophin releasing hormone stimulation tests, which helps differentiate between central and peripheral types. Bone age X-ray, which shows advanced skeletal maturation, and imaging like magnetic imaging resonance or the ultrasound to rule out CNS tumors or adrenal gonadal pathology. For the central precocious puberty, you could do the GnRH analogs like the leuprolide to delay further development. For the peripheral precocious puberty, you treat underlying cause, e.g. the tumor removal, steroid management in CH. Psychosocial support, you address emotional and the social concern. Remember, patients are going to present with hair growth, breast padding, pimples and acne, periods, high spat, and mood swing. So for the next disorder is the growth hormone deficiency. Growth hormone deficiencies are common in which the pituitary gland does not produce enough growth hormone, leading to impaired growth and development in children. So we have types also. We have the congenital type, which is present at birth due to genetic mutations or structural brain abnormalities. We also have the acquired growth hormone deficiency, which develops later due to brain tumors, radiation therapy, head trauma, or infections like meningitis. And lastly, we have idiopathic growth hormone deficiency, where there is no identifiable cause. In terms of manifestation, we have short stature, where we have a height of about 30 percentile of age, proportionate body size but slow growth rate. We have delayed puberty or absent puberty, increased fat deposition, especially around the abdomen, immature facial expression, frontal bossing, and mid-facial hypoplasia. And then we have hypoglycemia in infants due to impaired gluconeogenesis. In terms of diagnosis, you could do growth charts that will show decreased growth, velocity in normal weight gain. We also have the serum IGF-1 and IGF-BP3 levels that will show low growth hormone deficiency and indirect markers, of course, of growth hormone function. Growth hormone stimulation test use insulin, arginine, or clonidine to stimulate growth hormone secretion. Bone age X-ray will show delayed skeletal maturation, while MRI brain will be used to rule out pituitary or hypothalamic tumors. Management could do recumbent human growth hormone therapy. This is normally given subcutaneously daily and started as early as possible for better outcomes. You could also monitor growth progress every 4 to 6 months and manage underlying causes, e.g., tumor removal if it is present. Remember, the growth hormone has several implications in somebody's life. We could have, if you have hyposecretion of growth hormone in childhood, it could result into dwarfism. And if you have excessive growth hormone secretions in early childhood, it could lead to gigantism. And if you're having growth hormone excess in adulthood, the patient could suffer from acromegaly, that is characterized by prominent forehead, enlarged nose, enlarged lips and tongue, and prominent chin and jaw. So we normally do Turner staging of pubertal development, and Turner staging is simply a classification system used to assess pubertal development in children and adolescents. So it's divided into 5 stages for both males and females based on either breast development for the females, genital development for the males, or pubic hair for both. If you look at the first one, which is the breast development for the females, you could be classified in stage 1 as pre-pubertal stage if there is no glandular tissue, like in the case here, or stage 2 if there is breast budding, small mound formation, or stage 3 where there is enlargement of the breast and areola but no separation. Then stage 4 where we have areola form secondary, can be able to see here the stage 4. Areola forms a secondary mold over the breast. And then lastly, we have a mature breast contour, right? That is now the stage 5. So you can either classify the girl in stage 1, stage 2, stage 3, stage 4 based on the presentation. As for the males, you could look at now the genital development. So we could have pre-pubertal genitalia, where we have small testes, no penile growth. Stage 2, there is enlargement of the testes and the scrotum with reddening and the thinning of the scrotum, but no enlargement of the penis. Then we have stage 3 now, where the penis begins to enlarge in length and later in diameter. The testes and scrotum continue to enlarge. Stage 4, we have further growth of the penis, especially in the width, while darkening the scrotal skin. Then stage 5, we have now the adult type, fully developed testes, scrotum, and the penis. For both pubic hair, we have stage 1 where there is no pubic hair, that is prepubertal. For stage 2, we have sparse, light-colored, straight hair along the labia base of the penis. And then stage 3, we have darker, coarser, and curlier hair spreading over the pubic hair. Stage 4, we have the adult like hair quality but limited to pubic region. Stage 5 now we have full adult with hair distribution including the inner thighs. Okay guys, we have looked at different endocrine disorders. Let's look at also some of the metabolic disorders, and we can start with the first one, that is galactosemia. Is the inability of the patient to metabolize galactose in carbohydrate to glucose, and this is due to missing hepatic enzyme GALT, resulting into build up of galactose in blood and causing liver dysfunction. So the patient is going to present with vomiting following intake of milk, They are also going to have a weight loss, diarrhea, jaundice, and lethargy. So if a galactosemic infant is given milk and metabolized milk, sugars build up and damage the liver, the eyes, the skin, and the brain. In diagnostics, you could do serum where you're going to have the increased galactose. Could look at the blood where they are going to have decreased or absent GALT activity in the erythrocytes. If you look at the urine, you're going to have increased galactose. In terms of treatment, you do galactose or lactose-free diet. So you need to avoid dairy products, canned and frozen foods that contain lactose, cakes, cookies, pies, food coloring. Nursing intervention, you need to explain to the family and child the importance of avoiding dietary galactose. The other condition is have the Graves' disease. The Graves' disease here is an overproduction of the T3, T4 by the thyroid gland, and it can be caused by an autoimmune disease, a benign tumor, like adenoma, resulting in enlarged thyroid gland and overproduction of TSH, thyroid stimulating hormone, by the pituitary gland, caused by a pituitary gland. The prognosis is good if the cause is treated. However, this is a chronic disease. Signs such as the bulging of the eyes, the one that is referred to as exophthalmos, are not reversible. Furthermore, thyroid surgery may result into several complications. In terms of assessment, you find you have enlarged thyroid gland, the goiter caused by the tumor, protrusion of the eyes that you have referred to as the ophthalmos due to lymphocytic infiltration that pushes out the air ball, irritability, sweating, that's diaphoresis, excessive thyroid hormone raises the metabolic rate, and that's why I explained the sweating. Increased appetite due to increased metabolism, and hyperactivity due to high levels of thyroid hormone. Patient could also experience weight loss due to increased metabolism and insomnia due to increased metabolism. Diagnostics, you do serum where you are going to witness the increased serum T3, T4. Radio immunoassay will show increased T4. Serum, we have increased TRH, TSH if the pituitary gland is the cause of the hyperthyroidism. Serum will also show the presence of antibodies if the cause is the Graves' disease. The thyroid scan can also show an enlarged thyroid. For treatment, for mild cases and for young patients, you administer antithyroid medication such as the propionuracil or the methimazole to block the synthesis of T3 and T4. For severe cases where size of the thyroid gland interferes with swallowing or breathing, the thyroid gland is surgically reduced in size or removed. The patient must be on lifelong thyroid replacement therapy. Nursing intervention, you have to monitor vital signs, provide cool environment, provide a quiet environment, protect the patient's eyes with dark glasses and artificial tears if the patient has exophthalmos. You also need to provide a diet high in carbohydrates, proteins, calories, vitamins, and minerals. After surgery, you need to monitor for laryngeal edema following surgery so that you rule out the hoarseness or the inability to speak clearly. Keep oxygen, suction, and a tracheostomy set near the bed in the case of neck swells and breathing is impaired. Keep calcium gluconate near the patient's bed following surgery, which is the treatment for tetany to maintain the serum calcium level in normal range. Place the patient in semifolus position to decrease tension on the neck following surgery. Support the patient's head and neck with pillows following surgery. You need to monitor for muscle spasms and tremors, the tetany caused by manipulation of the thyroid gland during surgery. Check for drainage, hemorrhage from the incisions line. Red flags are frank hemorrhage and purulent foul smelling discharge. After surgery, you need to monitor for signs of hypoglycemia like tingling of the hands and the fingers. You check for Shevstov sign. This is by just simply tapping the nerve, the facial nerve in the face that will cause the facial muscles to twitch. You could also we could also do the Hose sign, where you're going to inflate the BP curve on the arm and the muscle will contract. These signs are normally positive when the parathyroid gland has been manipulated during thyroid surgery, in which case they secrete too much phosphorus and not enough calcium. Because of muscle and the heart need calcium for the work, a low level of calcium level may cause spasms of the muscles, which can easily be detected by the Shovstek sign and the Trocher sign. The treatment is intravenous calcium that is administered quickly, and you check for Trocher sign, right? You inflate, and this is what you're about to see. The next metabolic disorder is the maple syrup urine disease. Maple syrup is a rare genetic disorder. The body can't break down branched amino acids like the valine, leucine, and isoleucine. Patients present with maple syrup odor from urine. They could also present with seizures, difficulty in feeding, and motor reflex could be absent. Patient could also have abnormal respirations. You could diagnose by looking at the serum, where it will show increased branch chain amino acids. Could also do urine, look at the urine, where it will show also increased branch chain amino acids, and also arterial blood gases, which could show acidosis. Treatment, you increase dietary thiamine and you avoid dietary isoleucine, valine, and leucine. Hemodialysis can be done to remove branched chain amino acid from the body. Nursing intervention, you need to perform urine and blood test following the first day of feeding. You could also assess diapers for maple syrup odor and teach the parents the importance of avoiding foods that contain isoleucine, valine, and leucine. The other metabolic condition is phenylketonuria, and this is an autosomal genetic disorder, and there's mutation that causes for the hepatic enzyme phenylalanine hydroxylase. So we have two copies of mutated gene, one from the parent, from the father, and one from the mom. This enzyme is normally used to convert phenylalanine to thyroxine, resulting in accumulation of phenylalanine in the body that can cause mental retardation. In terms of clinical manifestation, we are going to have a history of phenylketonuria from the family, mental retardation as early as 4 months of age, could have dry skin, microcephaly, irritable, hyperreactive, musty skin odor, and even seizures later in life. The common testing point for the NCLEX is that the child has normal blood phenyl levels at birth. However, levels increase after birth. It can result into irreversible damage by 2 years of age if not detected and treated. You could do the Goodyear screening test, where it will show increased blood level in phenylalanine 4 days after birth. Treatment, you maintain blood levels of phenylalanine between 3 to 6 milligrams per deciliter by restricting dietary phenylalanine like the protein-rich foods. You administer enzyme hydroxylate of casein in place of milk. You explain to the family that the child should avoid eggs, meat, fish, poultry, breads, aspartame, and cheese for the child's entire life. The blood level of phenylalanine must be tested throughout the child's life to ensure that it remains within the desired level, 3 to 9. NCLEX point is that you need to be alert for signs of phenylalanine deficiency. Patient could present with anorexia, skin rashes, anemia, diarrhea, lethargy that may occur from too little phenylalanine in the diet. The other metabolic disorder is the glycogen storage diseases. We have type 1 and type 2. Type 1 is the von Kierke and the type 2 is the Pompe's disease. So von Kierke is a glycogen storage disease where metabolic disorders caused by enzyme deficiencies affecting glycogen metabolism. So what is deficiency enzyme in von Kierke is the glucose 6-phosphatase or the glucose 6-phosphatase type 1A or type 1B. and it is autosomal recessive disorder, so you might receive two defects from the father and the mother. Affected organs are majorly the liver and the kidneys, and it leads to impaired conversion of glucose 6-phosphate to glucose, leading to glycogen accumulation in the liver and the kidneys, causing severe fasting hypoglycemia. Von Gierke patients will present with severe fasting hypoglycemia, hepatomegaly, that's enlarged liver due to glycogen storages or accumulation, lactic acidosis, hyperuricemia due to increased purine metabolism, hyperlipidemia, milk plasma appearance, and dolly-like faces with fat cheeks and growth retardation. In terms of management, you could do frequent feeding with the Connach to prevent hypoglycemia and avoidance of galactose and fructose. You could use allopurinol for hyperuricemia and liver transplantation in severe cases. The second type of glycogen storage disorder is the Pompe's disease. Remember, alcohol should never be your first friend, so that's why we should remember that Pompe, in Swahili, Pompe, alcohol is Pompe in Swahili, so Pompe should be type 2, not your first. All right. It's also a glycogen storage disease, and we have enzyme deficiencies affecting glycogen metabolism. In this case, the deficient enzyme is acid alpha glucosidase or acid maltase, and is also an autosomal recessive. Affected organs are mainly the muscles, mostly the cardiac, skeletal, and smooth. So we have lysosomal enzyme deficiency that leads to glycogen accumulation within lysosomes, particularly affecting the cardiac and the skeletal muscles. So patients are going to present with infantile form, which is the most severe form, cardiomegaly, hypertrophic cardiomyopathy, and this could lead to heart failure, hypotonia, that's floppy baby syndrome, respiratory failure, death by 2 years if untreated. Late onset form, this is a milder form, and this is characterized by progressive muscle weakness. Respiratory failure is the leading cause of death in these patients. There's no significant cardiac involvement in the late onset form. Management, we would do enzyme replacement therapy with recombinant alpha glucosidase and supportive care, so that support the respiratory and also the physical therapy. We also have the mitochondrial disorders like the Leigh syndrome, and these are a group of genetic conditions caused by defects in mitochondrial function leading to impaired energy production. So the Leigh syndrome is a severe neurodegenerative disorder resulting from mitochondrial dysfunction. So we have mutation in mitochondrial DNA or nuclear DNA affecting oxidative phosphorylation. This leads to energy deficiency, especially in high energy or demanding organs like the brain, the muscles, and the heart. Then they will have progressive neurodegeneration due to impaired ATP production. Patients are going to present with the Leo syndrome, like the subacute necrotizing encephalopathy, where the onset is in infancy or either early childhood. We also have neurodevelopment regression, so there's loss of milestone, hypotonia, muscle weakness and dystonia, seizures and ataxia. We also have lactic acidosis due to mitochondrial dysfunction and respiratory failure, especially the brain, because of the brainstem involvement. Other mitochondrial disorders include mitochondrial myopathy, the MELAS, the Leber's hereditary optic neuropathy. In terms of diagnostic, we do serum CSF lactate, where we are going to have elevated in mitochondrial dysfunction. It will be elevated in mitochondrial dysfunction. The muscle biopsy, the rugged red fibers will be abnormal in mitochondria. MRI brain will have bilateral basal ganglia or brain stem lesions, and genetic testing will identify mitochondrial DNA mutations. In terms of management, you do supportive care, so there is no cure. Do nutritional supplements, the coenzymes Q10 and riboflavin, the L-carnitine. Avoid metabolic stressors, so you minimize fasting, infection, and oxidative stress. physical and occupational therapy for symptom management, and the respiratory support if the brain is affected. Remember, we have some of the nursing diagnoses that could affecting these disorders that we've just mentioned today. We could talk of the risk of imbalance growth and development related to growth hormone deficiency. We'll also have congenital hypothyroidism or precocious puberty. Number two, we could talk of risk for unstable blood glucose level related to type 1 diabetes, congenital adrenal hyperplasia, or even glucogen storage diseases like the von Gehrke and the Pompe's disease. Imbalanced nutrition less than body requirement, and actually this one is an actual one related to malabsorption in metabolic disorders, e.g. when you're talking of the phenylketonuria or galactosemia. Risk for electrolyte imbalance related to adrenal insufficiency like for the diabetes insipidus and the hyperparathyroidism. Fatigue related to hypothyroidism, mitochondrial disorders, anemia from metabolic conditions, delayed growth and development related to congenital hypothyroidism, Turner syndrome, pituitary disorders, risk for impaired skin integrity related to poor circulation and delayed wound healing in diabetes mellitus, risk for impaired cognitive development related to untreated phenylketonuria, hypothyroidism, and metabolic acidosis, and risk for fluid volume deficit related to diabetes insipidus, adrenal crisis, dehydration from metabolic disorders. Lastly, you could have risk for infection related to immunosuppression from long-term steroid use, like for the case of congenital adrenal hyperplasia or the Cushing syndrome. So that marks the end of our presentation today. So today we have been able to look at several factors. We have looked at the endocrine disorders, and we have also looked at the metabolic disorders. We looked at the Turner staging, and lastly given nursing diagnoses related to the metabolic and endocrine disorders in pediatric patients. Thank you so much. You could go through the content if you find it enough for the nursing students. You could share with them and we share the feedback.